My name is Shannon Thomas. I'm a vascular, endovascular and renal transplant surgeon at the Prince of Wales Hospital, and I'm also a senior lecturer at the University of New South Wales in Sydney, Australia. The real importance of this study is that if you have kidney failure, or if you have a patient that has kidney failure, then in most countries around the world, the way that they are going to stay alive is with dialysis. And most people in the world, even though transplant is the best way, most people end up on hemodialysis. And that is where two needles are put into a fistula or an enlarged vein, usually in the arms. One needle takes the blood out into the dialysis machine, filters it, and then sends it back through the second needle. Now, the problem is that making a fistula for a patient is actually difficult. And there was a meta-analysis in 2017 in the European Journal of Vascular Surgery that showed some 22% of fistulas were only working at 6 months. So the majority of fistulas that were made never worked. And about 21% were just abandoned without any form of revision. So that's a real problem. And where this paper, or where this study finds its importance is in addressing that issue, where we we join the artery to the vein to make the fistula for the patient, and then we use stents or balloons to cause it to grow into something that is useful, such that at 6 months, 94% of fistulas are good to go. They're ready to be used, or they are already being used. And so it's a massive paradigm shift in the way that patients with hemodialysis-dependent kidney failure are managed. So we performed a retrospective single cohort study of patients who had never had any vascular access before, who presented to our institution over a 6-year time period for vascular access. So these patients basically had developed kidney failure for the first time in their lives, and we made a fistula for them.